Now we will go to the second presentation with our beloved professor, Professor Mohamed Imam from UK. We'll speak about the terrible triad of the elbow.
Thank you very much, Professor Mohammed, for the kind words and for inviting me to give this talk. It's really helpful that yesterday Dr. Professor Mohammed Salah gave a very good talk summarizing fracture dislocations around the elbow. So I'm going to take a thorough, in-depth view towards terrible terrible triad of the elbow. So basically, terrible triads, who sees these injuries? That's a common question. And do all of us as orthopedic surgeons should be aware of this critical injury? I think all of us see these injuries, and actually any general orthopedic surgeon will see someone with elbow instability at some point in their practice, either in an A&E or in an outpatient clinic. And does it matter? I think it does, and we'll mention that at the end. So basically, elbow stability is a function of osseous and ligamentous constraints, as well as musculotendinous control. So in order to manage these type of injuries properly, you have to understand the anatomy, understand and recognize the pattern of the injury, and have an algorithm for management. While we often think of static and dynamic restraints, O'Driscoll from Mayo Clinic has described the forces of stability, which consider both dynamic and static restraints as primary and secondary stabilizers. Primary restraints mentioned here, secondary restraints mentioned here. The capsule is crucial. What we should also be aware that the interosseous ligaments, and mainly the quadrate ligament and the central ligament, actually have a role as well of elbow stability. But what we know so far, what we were taught before, we were taught that for most elbow dislocation will occur as part of axial load, valgus force, and forearm supination. Here, Horry describes a circle of Horry, or circle of injury, from lateral to medial, with the first structure to fail is the lateral ulnar collateral ligament, followed by the radial head, and then the capsule from anterior to posterior, and finally the medial ulnar collateral ligament. But is that true? Many reports have refuted the pathogenesis. Here we see an MRI of an elbow dislocation. The only ligament that's torn is the medial collateral ligament. Did that patient didn't recognize the circle of Horry and while falling? That's a question. But actually, that was proved by many others. So actually, there are different possibilities. So it can start medial and can start lateral. And our concepts about the circle of Horry might not be the right concept. So Adam Watts from Writington, and I'll mention Writington on a few occasions. I'm a bit biased because I'm an ex-Writington fellow, but that's actually in that study we looked looking at the type of injury. In majority of patients, they have a medial ligament tear followed by common flexor origin avulsion, anterior capsule tear, and so on. So actually, what we have to discuss, and that's how I look at elbow instability now in our clinics and when on call. Elbow stability, function of osseous and ligamentous structure. So the contribution on medial and lateral aspects aren't the same. We always discuss distal humeral fractures as 3 columns, like my talk yesterday, but actually the same is applied here. We have on the medial side, the olecranon, the coronoid process includes the medial trochlea through an arc of 170 degrees. So it is very congruent, very constrained bony structure. So the stability on the medial side is mainly bony. However, if we look at the radial head is relatively incongruent with greater arc of curvature than the capitellum, shallower concave surface that only covers the capitellum over an arc of around 90 degrees. So on the lateral side, it's actually dynamic and static stabilizers and ligamentous structures constitute more into the stability than the medial side. We were taught The Mori classification, looking at the tip on lateral radiograph, that this is how to classify coronoid fractures. But what was missed is actually the coronoid is a fan-like structure that project anteriorly, and so what can appear to be a tip fracture might be a bigger fracture actually extending into the anteromedial and the anterolateral facet, and that actually dictate our treatment. For those who fix a lot of coronoid fractures, if you do what is 2 millimeter is actually bigger always, because there is big piece of cartilage attached to it, and Scott Steinman from Mayo Clinic have wrote a couple of papers on this regard as well. So the important elements of coronoid process, if we look at it and how important it is for stability, includes the sublim tubercle and the anterior medial collateral ligament, which is the strongest ligament there. The anteromedial anterolateral facets are crucial adjuvants to stability. And if we look here, we'll find the anteromedial and anterolateral facets separated by a ridge of bone, which runs the length of the greater sigmoid notch. If we look actually from a biomechanical studies, the anteromedial facet has a surface area of around 23 centimeter compared to a mean radial head surface area of 24 centimeter square. So making, or 230 millimeter, making it anteromedial facet a vital primary stabilizer. And I cannot emphasize how important is to understand whether the fracture is extending into the anteromedial facet or not. The anterolateral facet is a second degree stabilizer with a mean surface area of around 14 centimeters square, and the anterior capsule and precalis have important role there as well. So what about the lateral collateral complex? The lateral collateral complex is a condensation of the lateral capsule, the most important of which is the lateral ulnar collateral ligament. There are important ligaments there, including the annular ligament, the radial collateral ligament, the accessory lateral ulnar collateral ligament, and recently we know that there is the posterolateral ligament, which is of significant importance to posterior stability of the radial head. So how to look at instability now? So this is also so in order to understand the impact of the injury to these osseous elements for elbow instability, we should consider the proximal forearm to be of 3 columns. The lateral column consists, as per this picture, of the radial head and the capitellum, middle anterolateral facet of the coronoid and the lateral trochlea, and the medial column, which is the anteromedial facet and the medial trochlea. With the fulcrum, so bearing in mind the axis, the loading forces, the joint reaction forces around the elbow, we can identify the fulcrum, main fulcrum here for stability, for varus valgus stability, lies between the medial and the middle column. So the primary restraint here to valgus is the lateral column, and secondary contribution of the middle column, and the primary restraint to varus collapse is the medial column. So the middle column, might be not important when the lateral column is function, or if you have 2 columns there, which is rare to have an anterolateral facet fracture. But it's important to recognize that these osseous or bony injury patterns are associated with particular soft tissue injury, which would contribute to instability. The lateral complex is the most important soft tissue, as we've mentioned earlier, because stability on the lateral aspect is more ligamentous than bony. So in order to understand elbow instability, now we had an idea about the column structures and the soft and bony structures. So what are the types of elbow instability? Generally speaking, it was nicely presented yesterday, and but we can classify into a different way. Posterior rotatory, in which there is a pronation lateral rotation from medial to lateral, which is the terrible triad, or the other side, which is the posteromedial instability. Transolecral instability, either apex anterior or posterior, like Montegia fractures, or the longitudinal instability, which is more a forearm instability, as the case of Essex leprosity lesions. So we'll try to focus in this talk on the terrible triad, which is the commonest of all instability. And we have been taught in residency and training that it is a triad of elbow dislocation with lateral collateral ligament disruption, radial head or neck fracture associated with coronoid fracture, and sometimes medial collateral ligament, which is in essence the same thing. So what is the Writington classification? And so Writington classification, it is basically looking at stability from a different perspective. Look, with type D is actually the Montegia type, which we can exclude. Now we have three main types, whether the anteromedial type, which is type A, which is anteromedial facet, or a bifacet, or type C, which is what we call terrible triad. So in type A, actually, right, if you look at type A fractures, there is loss of the medial column because the anteromedial facet is broken, associated proximal avulsion of the lateral ligamentous complex, which happen in all of them, and posterior band of the medial collateral ligament will result in varus instability. So that's what we call posteromedial rotatory instability. So what about posteromedial rotatory instability? So what about type C? In type C, it's a terrible triad. It's combined loss of the middle, which is the anterolateral facet, and the lateral, the radial head columns, with disruption of the lateral collateral ligament disruption, and the patient has valgus instability. It is similar to, that's what we call terrible triad. So in order to reverse the injury, we have to reconstruct the column. So you have to reconstruct the radial head, the lateral collateral ligament, as we, in actually type C, Writington, you don't have to reconstruct the coronoid. When do you have to reconstruct the coronoid? If it is type B and there is extension into the anterolateral facet. We are lucky now that we can see actually terrible triad happening live. The main goalkeeper of Tottenham, Lloris, having this injury a couple of years ago, landing in valgus axial loading injury, sustaining a tibial triad. These are not his scans, but and then what we should do when we see someone, when we suspect a terrible triad injury, it's a high, we have to tell the patient the gravity of the situation, and the algorithm for managing Writington type C is well described, and the same principles for all terrible triad, which is radial head fixed or replaced, lateral ligament repaired, and the C, whether you need to reconstruct the anterolateral facet or not. If the coronoid fracture actually extend into the other facet, you must fix the coronoid, because that's now type B, which is a bifacetal variation. Because the residual instability here will result in stiffness. And of course, we'll discuss the algorithm for treatment. So later on. So what do we do in these? So actually, the algorithm we use where we are, you restore the coronoid first through lateral. You can access that, or through a medial and lateral approach, or posterior approach, modified Writington approach. It's all dependent on the amount of displacement and the morphology of the fracture. After restoring coronoid, you restore the radial head, and then I repair the lateral ligamentous complex, assess. If you need to, then you can restore the medial soft tissue. If all that fails and the patient is still unstable, X-fix. Putting the patient in plaster isn't the best of options here, as I've highlighted as well yesterday, because the thing, unstable elbows are stiff elbows. So if you have an instability of the shoulder, your shoulder will keep popping out and in, out and in. But actually in elbows, if you have an unstable elbow, terrible triad, put him in plaster 4 weeks, he will have no range of, he or she will have no range of motion ever again. And that's a problem, because the bailout options here are very limited. So what do we do? CT scan, assess the geometry of the problem, undertake 3D reconstruction. What we tend to do in our center is to do humeral traction so that we can see the coronoid more. The plan for your fixation, you can easily fix the coronoid from the lateral aspect, or you can do a Hotchkiss approach from the medial side or posterior side. Start by assessing the coronoid. If it needs fixation, you can fix it with retrograde screws, lasso suture, plating, or even double plating if there is a facet, if there is an involvement of the two facets, if you need to achieve stability there. And after doing so, look at the radial head, manage the radial head either by absorbable screws, plate and screws, or radial head replacement, which is always a very good option whenever needed. The problem with radial head replacement is actually a main problem that I see is that all of us tend to overstuff the radial head. It's usually a size smaller than what you have in mind. And in order to gauge that, the best way is to look at the coronoid or the proximal radioulnar joint. So when you exercise your radial head, look at the tip of the coronoid and the joint line of the coronoid. Your radial head shouldn't be extending beyond that line, can be below it. The other option is to look at the resected head and assess the radial head height. One option is actually to do x-rays, and you should have conformity of the ulnohumeral joint. If you have gapping, you've oversized. Another option that sometimes you need to do is unlikely, but take a look x-ray on the other side, the ulna on the other side, and the x-ray, the ulna on this, the rest on this side, and see if you have changed ulnar variance. The different papers has published on how to achieve the right radial head. George et al. Have published few. This is the gapping, so that's how the radial head should be lying down, and that's an overstuffing of the radial head. Assessing the radial head in line with the coronoid. So actually in this paper, they said it's half a centimeter less. So simply you shouldn't, the end of your radial head shouldn't be beyond the joint line there. And fixation versus replacement, if you can fix it, but if it is unlikely that you will achieve good anatomic reductions that would enable early range of motion. If you have more than 3 fragments according to the paper by ring, then a replacement would be the best option. So what about soft tissue management? You've addressed your radial head, you've addressed your coronoid. So here, if you actually in closure, there are different ways of doing closure and repairing the soft tissue structure. So here, if you have the posterior half of the lateral collateral ligament is still attached to the lateral epicondyle, then the anterior half of it, or the annual ligament and the radial collateral ligament and the extensor muscle are repaired to the posterior half using interrupted absorbable sutures. However, if the lateral ulnar collateral ligament, if at the extensor origin has been completely disrupted by the injury or detached by surgical exposure, then you have to securely repair. Every terrible triad, I tend to repair the lateral collateral ligament if I have very low threshold to repair it. One option is to have a single drill hole in the center of the arc of curvature of the capitellum, connect two drill holes placed anterior and posterior in the lateral supracondylar ridge here, and do Krakow suture technique to gain secure hold of the lateral collateral ligament as well as the annular ligament. And then after that, a second stitch can be used in similar manner to repair the lateral and the common extensor muscle fascia. The sutures are pulled here after having that through the drill holes in the distal humerus using suture retrievals, which is the classic descripted. And then when you are doing that, you have to keep the arm pronated and so as to avoid varus forces and eventually tie over the lateral supracondylar ridge. You can use soft anchors, which is another easy option of doing the repair. If in doubt, I have low threshold of doing an internal brace to augment the repair if needed acutely. So if all that fails, only other option here would be external fixator. There is actually, companies now have internal infix which can be used. For this patient, actually, it was an open injury, so we opted for external fixator. So what approaches usually in acute scenario, you can start using the Cooker or Kaplan approach, and Prof. Mohammed have highlighted that yesterday. I think it's all about the dissection, because sometimes the dissection has already been done for you. So Cooker approach is my preferred approach. Make sure you have good access to the radial head. What you should be wary of here while repairing this is that, one, you have to be cautious with the protection of the posterior interosseous nerve. Pronation of the arm would move the nerve away from the operative field. Always remain subperiosteally whenever you're dissecting any of these. You have to have a low threshold for arthroplasty if there is comminution. Fluoroscopy is important, and I always examine these patients under anesthesia whenever I have to. Actually, all the time I do that. We have also to be extra cautious about the prosthetic radial head replacement. You should maintain the height as much as you can and never overstuff. Hinged external fixator has to be in each of these cases, at least one out of, I'm not sure how many. You will have to do that. A thorough fluoroscopic examination is the most important factor here in deciding if your treatment is appropriate. If there is incongruency at the end, that's incongruent joint. So a congruent joint would be congruent at all the time points. To obtain a true lateral view, you have to abduct the arm, external rotate the shoulder while placing the elbow on the image intensifier, which you have to do it. Sorry, I don't have a picture of the ideal one. So actually, so ideal lateral elbow X-ray. So that's just one case to discuss a couple of things here, how we should manage this meticulously. This is a terrible triad. It was fixed by someone else, and you can see the incongruency here. The surgeon accepted that, and now the patient is 44, very young, with marked stiffness, no pronosupination, and very limited flexion extension. We've done CT scans and ultrasound scans which have demonstrated that the lateral ulnar collateral appears to be intact, but the medial is gone and wasn't addressed. So what we've done is revised. The radial head was reduced 2 sizes. So there was oversizing here, and release, lateral corum release, internal brace on the medial side, lateral side, internal brace on the lateral side, over the top release, ulnar nerve transposition, because there is neuritis that happens as well, and the patient was delighted, had significantly improved function. At the end, we tend not to leave them in any sort of support. There are different algorithms out there about the management of these. This is published by Adam Watts about managing this type of injuries based on the Writington classification. However, a simple algorithm I would do: fix the coronoid fracture if you have to, fix or replace the radial head, repair the lateral ulnar collateral ligament, assess elbow stability within 30 to 130 degrees of flexion extension with the arm in full pronation. If unstable and there is varus instability, I'll repair the medial collateral ligament. If in worry, I would do external fixator to allow concentric reduction and allow for early motion. So post-operatively, as there are different protocols, try to avoid using heavy plaster, try to avoid immobilization of these. Armstrong, when you're doing back slab or supporting these with a hinged elbow brace, the thumb of the patient should be pointing towards the intact ligament. So that's the general rule of thumb. So actually, if you have to do a repair, so if the lateral collateral ligament is intact, then the thumb of the patient should be towards the lateral ulnar collateral ligaments, so the patient should be in supination. So does it matter? Yes, because you have to get it right from the first time if you can, because it's always this the gravity of these injuries. There are a lot of complex surgeries that we tend to do if things fail, but it's better to get it right from the first time. Thank you.
Thank you so much, Professor Mohamed Imam, for this very interesting talk and very detailed talk about the terrible triad of the elbow. Thank you so much, sir.
Thank you.
Dr. Ahmed Sheikh,
Yes,
you are ready to moderate the questions with Professor Imam?
absolutely. I got a question. What is the mechanism of X-fix after failed elbow ligaments repair or instability? I think you asked what's the use of external fixator if we fail to do the repair.
Actually, I'm talking, if you're doing an acute repair of a terrible triad, you've done everything. You've done the radial head, you've done your you've done the coronoid, you've done the ligament repair. However, the soft tissue damage is huge, and still the elbow is still unstable. The external fixator, you do what we do is the striker one in my unit. So we do, so you have a center of rotation adjusted at the condyles, and that will enable the patient to do range of motion exercises immediately. That's what I meant by external fixator. If there is failed repair of the ligaments later on, external fixator can have a role as well, but we have different options of managing these for neglected or mismanaged injuries.
Thank you. Waiting for any further questions. I think it's a very illustrative talk. You have mentioned everything, I think.
Yes, so because it's Professor Mohamed mentioned stuff about elbow fracture dislocation elbow, so I had to lift the bar a bit.
yeah, absolutely. One of our colleagues said recently some author didn't repair the MCL and did a hinged X-fix because of the high rate of heterotropic ossification. It's a good question to highlight the situation of heterotropic ossification, what increases or what decreases the incidence of happening.
So heterotopic ossification is one of the things that I mentioned to all these patients while they are undertaking surgery, because it's partly as well of the disruption mechanism of having an elbow dislocation, the disruption of the interosseous ligament as well, which is also associated with this type of injury. And there is small bony fragments that happen after a dislocation, especially if you're not doing a posterior approach and going through everything, seeing things. We always have limited view in elbow fixation, especially in case of fractures. So there are a lot of factors there about heterotopic ossification, and one of the most important bits is actually immobilization as well. So I think, you know, if the elbow is stable up to 40 degrees or 30 degrees of extension, you can manage the MCL non-operatively. But I think it's better to address things from the first time if you can. If there is a confirmed medial collateral ligament disruption, I'll have a very low threshold of repairing it. But if I repair everything and things looks all right and looks stable, I'll manage that non-operatively. So that's a valid way of managing it.
Yeah, we mentioned the ligaments on the medial and the lateral, but one of our colleagues asked about the anterior capsule reconstruction. Is there any rule? Yes,
so actually it depends. So anterior capsule is a secondary stabilizer. If you look about sorry, it's a capsule. If you look at what I've mentioned about secondary stabilizers there, but capsule I'll have, so if I have a small tip fracture of the coronoid and I feel it's unstable, what I tend to do, either the lasso suture or I can put a soft tissue anchor into the capsule, bring it back into position, and I have few x-rays with this and repair it back into position. But it's according to our protocol, it's always you test stability. So if there is, you know, you can address everything. You can mention the anterior, the capsule, you can mention the brachialis disruptions. There is a lot of disrupted soft tissue there. But I think the capsule is, you can address the capsule in your management of the coronoid as well as your repair of the soft tissue at the end.
Okay. One of our colleagues also add another level of difficulty. What if you have olecranon fracture? So how would this change your approach? Or
well, actually, it depends on the associated injuries as well. So when you have olecranon fracture, you have to make sure you're not missing what's happening. If it is Montegia, I'll manage it as a Montegia fracture and address the associated injuries there. But if it is terrible triad with olecranon fracture, which isn't a very common variation, you can then use I'll go from the posterior approach. I'll use the posterior approach there, or the modified Writington approach, having an 8 centimeter longitudinal, 10 centimeter longitudinal incision at the junction of the ulna and the anconeus. And then go through the interval between the ulna and the anconeus with care taken not to violate the periosteum or the muscle to minimize the risk of synostosis and heterotopic ossification. You can then lift the anconeus to avoid damage the capsule and the lateral ligament, and you can address all through the posterior approach if you have to, which is a very good question. Hopefully, it's not. Luckily, it's not a very common injury.
Yeah, absolutely. What about excision of the radial head fragment, which is less than 25% of the equator?
It is, we tend not to excise them now because we can easily fix them. And actually, radial head excision is obsolete now. I would never excise the radial head because, even our lower limb colleagues do radial head replacements in our departments. They don't do it great, but they do it. So it's actually, you can see that done by everyone. So it's a simple surgery that takes 15 minutes. So we don't excise it. If it is a small fragment, I'll fix it. If it is an extra articular, very small fragment, I can excise it. Theoretically, it wouldn't affect the outcome.
Okay. I think it's another question about the approach. So we'll just repeat it to consolidate the information. Would you select your approach a universal posterior approach or lateral window or double window? How would you decide
You make your mind before surgery. So there is an important quote in surgery, which is decisions are more important than incisions. So you have to plan your surgery properly, and then you can identify this. I have used the posterior approach. I've used the modified Writington approach, but main approach for this would be the lateral approach, the Kaplan one, address everything from the medial side. If I have to do another approach, I'll go medially, and I'll have good access to that, because not usually you have to open the medial side. That's my personal preference.
Yeah. Last question about coronoid plating. How far should the plate from the tip or from the articular side? Precautions or measurements for coronoid plating?
So, Hodgkin's approach will be enough to address an isolated coronoid fracture. You have to be fully aware. If you have a big fragment and dislocated radial head, that's a Montegia fracture more than a terrible triad for injuries. That's what's important about this classification. So you can, as a bespoke coronoid fracture, I'll do it long enough in order to address the fracture properly.
Yeah, I think we're done with the questions, and you have almost mentioned everything. Really appreciate it. I really enjoyed it. Thanks so much, Mr. Imam, for
It's my pleasure. It's my pleasure.
Thank you, Mr. Imam, for this wonderful talk. And I just want to finish this night with the question about your experience in chronic neglected elbow dislocations, how you manage them.
So it is, this is usually this is one of the worst difficult scenarios that you find yourself in. Because with chronic, and actually it's even worse with those with hidden injuries. So sometimes we can see someone who have had a soft tissue injury with bad pain, and all ligaments are disrupted and they develop stiffness. So these patients will either complain of pain on the medial or the lateral aspects of the elbow. So it's all about patient history and imaging and understanding the situation, and it depends actually on their age. So if it is a chronic dislocated or mismanaged elbow in someone above the age of 60 or 70, might be a total elbow replacement the best option. If it is a neglected isolated medial collateral ligament disruption, the docking, I will address each situation by itself. If they develop bad arthritis and it's irreversible, I'll have to be I'll have to be very honest with the patient in order to have realistic expectation before managing these. But that's one of the worst situations we find ourselves in upper limb as well, in upper limb surgery, as you're aware.
Thank you.
Thank you.
Thank you so much, Mr. Imam, for this interesting talk. احنا طبعا نشكر تواجد حضرتك معانا في يومين متواصلين، وده طبعا اوفرلود على حضرتك كبير قوي. شكرا جزيلا استاذنا الفاضل.
طبعا وما شاء الله ربنا يجازيكم خير على المجهود الكبير اللي عاملينه ما شاء الله.
Thank you so much, sir. وطبعا many thanks to Professor Mohamed Salah for being with us on 2 consecutive nights.